So, 3, 2, 1. Hello, everyone. And today we are discussing the most important topic of the time today because metastasis is the #1 indication for the radiosurgery throughout the globe. And this is one disease which is at an intersection of neurosurgeon, radiation oncologist, medical oncologist. There are various primary pathologies, primary organs from where the metastasis happens to the brain. And this is going to be an interesting session. So I request my co-chair, Professor Selçuk Peker, to introduce our young and dynamic speaker today. Over to you, Professor Peker.
Dear colleagues, good afternoon. Today we have a distinguished speaker in Gamma Knife Radiosurgery world and our friend for many years, Professor Dr. Amr El-Shiabi. So Dr. El-Shiabi is the Deputy Medical Director of Gamma Knife Center, Cairo, and is a professor of neurosurgery, and he is still working in Ain Shams University, Faculty of Medicine in Cairo, Egypt. And he performed his doctoral thesis on gamma knife radiosurgery as a treatment of modality in intracranial meningiomas. And he was the part of the first gamma knife radiosurgery program in Egypt, and it started in 2001 in Gamma Knife Center at Nasser Institute Hospital, also in Cairo. And he was published a lot of articles on stereotactic radiosurgery for a lot of different subjects, and we are all together working in the IRF projects too. And he personally treated more than 16,000 patients since 2001, and also he is a faculty member in ISR's educational courses since 2019. And we are very glad to get his presentation about radiosurgery for solitary brain metastasis, which is, I think, the most important subject today in all over the world, metastasis. And now the stage is yours, Professor El-Shiabi, please.
Thank you very much. Good day, everybody. Thank you for the kind introduction, Dr. Peker. Let me close the camera. Okay, today I will be talking about brain radiosurgery for brain metastasis, like Dr. Peker said. Of course, as we know, this is the commonest indication for cranial radiosurgery.
Dr. Shiabi, sorry, we are not able to see your screen, so if you can please share it with us.
So
not yet. Yes, it's coming. Yes, please put it on the presenter mode, please. Thank you. And I request all the delegates to kindly mute themselves so that there is no interruption of the voice in between. Thank you. Over to you, Dr. Shiabi.
Okay, so as I said, it's the commonest indication for cranial radiosurgery. As we all know, it was an evolution out of whole brain radiotherapy for treatment of brain metastases. However, we know brain metastases are a diverse group of tumors that, as regards to the primary tumor or the location or the primary control, and many other factors that can affect the management and make it sometimes problematic. So during this talk, I will try to walk you through the treatment paradigm of these tumors to find how best way to manage them. We know that brain metastases occur in 20 to 40% of cancer patients. The commonest cancer to send metastasis to the brain is lung cancer. However, lung cancer usually causes polymetastatic lesion or disease rather than solitary, probably because of their propensity for a more extensive hematogenous spread because of direct access to the pulmonary circulation and because of their aggressive nature. Also, melanomas usually metastasize, but more also polymetastatic disease because of their vascularity. They tend to spread through the blood, and so more extensive. The commonest cancer to send solitary lesions to the brain is breast cancer, followed by colorectal and renal cell carcinoma. As I said in the beginning, radiosurgery was an evolution out of whole brain radiotherapy. It was the standard of care a while ago, but it was plagued with its complications, mainly the neurocognitive complications. Later on, surgery was added to the mix in order to decrease the tumor burden and improve the results of whole brain radiotherapy. And finally, radiosurgery caught up, and it provided a focal or a more focal means for radiation for these tumors. Brain metastases can either be synchronous, as they are discovered as the primary lesion at the same time of the primary lesion, or as the first presentation from a primary lesion, or they can be metachronous, as discovered after an interval from the primary. Solitary metastases are by definition a single lesion with no systemic metastasis, while single metastases are a single lesion with systemic metastasis. Oligometastatic is usually 2 to 4 lesions, or sometimes referred to less than 5 or less, and polymetastatic is more than that. The rationale for using radiosurgery for solitary metastasis, of course, is first of all the ability to give a high dose in a single, usually a single fraction with a steep radiation fall-off, providing better tumor control and avoiding the neurocognitive complications of whole brain radiotherapy. Its main advantage also can be repeated for the same lesion or for a new distant brain metastasis, and is reported to improve survival. Patient selection, according to the WFNS and CNS approved evidence, the general criteria are a prognosis of 6 months or more, a controlled extracranial disease, a KPS of 70 or more, and age is not a disqualifying factor. A lesion size of 4 centimeters or less for single fraction. The ASTRO guidelines permit up to 6 centimeters. With the current evidence that is available, we know that, or we found that radiosurgery combined with whole brain radiotherapy provided a better local control than whole brain radiotherapy alone. And we found that radiosurgery alone and versus radiosurgery and whole brain radiotherapy provided equal control, but with the advantage for radiosurgery is preservation of neurocognition. Post-operative radiosurgery can also be given as preferred with radiosurgery than whole brain radiotherapy for obviously the neurocognitive advantage. Several prognostic scales have been developed in order to guide the best management for these lesions. The non-tumor specific were the RPA, the recursive partitioning analysis, which included criteria such as the age, the brain tumor only, and KPS. Then several other scales were developed with the varying factors such as the primary control, extracranial disease, and number of brain metastases, up to the GPA, the graded prognostic assessment. A later evolution of this was the diagnosis-specific GPA. It was devised on a meta-analysis of more than 4,000 patients and included the histology, the KPS, the age, the number of metastases, and extracranial disease. But also it was found that the molecular markers were important in determining which management strategy to go for, especially lesions such as non-small cell lung carcinoma, the EGFR and ALK, and BRAF-positive melanomas. The emerging factors now are the tumor morphology. Sphericity was found to provide better prognosis. Neutrophil to lymphocyte ratio, the radiomics of MRI features, and the cumulative intracranial volume. It's found that less than 7 cc's was preferred. For treatment planning, the imaging, the MRI, of course, is the gold standard. Thin-cut MRI is preferred that the time from treatment planning to the planning MRI not exceed 7 days, because the tumor can grow by up to 20% in over 8 days. The target is the gross target volume. We do not routinely use the CTV or the clinical target volume. The PTV can be used for certain setups. You can set up uncertainties for certain platforms, radiation platforms, and we can find that a 1 millimeter margin doubles the volume of the lesion. There are several radiosurgery platforms that are used. Clinically, it was not found that there's a difference in the outcomes between these different platforms. But just of notice is that with Linacs, it was found that 6-MEV triple F is preferred over 10-MEV triple F because it provides a steeper radiation fall-off. For dose prescription, for single fraction, the RTOG benchmark study and RCR recommendations are that for lesion diameters 2 centimeters or less, 24 grays be used, and for 2 to 3, 18 grays, and for 3 to 4, 15 grays. The dose used is volume is size dependent, but as you can see, a jump in 1 centimeter from one diameter to the next results in considerable change in tumor volume, increase in tumor volume. That's why the dose should be de-escalated for larger lesions to decrease the amount of normal brain tissue that is receiving radiation around the tumor. And namely for this, we use the 12 gray volume around the tumor. It was found that for more than 5 cc's, there was a 10% risk and up to 20% risk for more than 15 cc. There were guidelines also for the cavity of post-surgical cavity radiosurgery for 4.2 cc or less, 20 grays, and for 4 to 8 cc's, 18 grays, and for 8 to 14 cc's, 17 grays. Fractionated in large tumors. For hypofractionated radiosurgery, here the rationale was to make use of the difference between the alpha and alpha beta ratio between the normal tissue, which is low, and the tumor tissue, which is high, equivalent to 10 grays. Widen the biologically equivalent dose and therapeutic window, increasing the tumor cell kill and decreasing the toxicity. For a high-tech study, which was a study that compared the different doses between single fraction and hypofractionation, found that local control was worse with single fraction when the diameter was more than 2 centimeters. But single fraction radiosurgery has the additional advantage of the ability to cause vascular damage and immune activation. The regimens that are usually recommended as ASTRO, as per ASTRO, the 27 Grays in 3 fractions or 30 Grays in 5 fractions. Some use 35 Grays in 5 fractions also. In a study that was assessing the different fractionation models between single and hyperfractionation, it found that with hyperfractionation, the local control was 90%, and in single fraction, it was lower. And also found that radionecrosis risk was lesser in hyperfractionation radiosurgery. There are still further trials that are comparing single to hyperfractionation in lesions 2 to 4 centimeters that are intact. The different management strategies of brain metastasis surgery and radiosurgery and whole brain radiotherapy provide a debate. The landmark studies initially found that surgery and whole brain radiotherapy versus whole brain radiotherapy provided better overall survival and quality of life, as well as local control. Later studies found no difference in the overall survival and equal local control. Post-operative radiosurgery versus whole brain radiotherapy after surgery. Meta-analysis included 4 studies, and it found no difference between giving radiosurgery or whole brain radiotherapy after surgery. The only superior advantage was for radiosurgery was the quality of life and neurocognitive preservation. However, for distant brain failure, there was a trend towards it being higher with radiosurgery. The current consensus is to use radiosurgery post-operative cavity, and when it is not suitable, whole brain radiotherapy may be used. A new treatment paradigm is now coming into effect, the preoperative radiosurgery. Of course, the problem with surgery in brain metastasis is the risk of leptomeningeal disease, as well as the interval from the time of surgery up to radiosurgery may allow the tumor to grow. And also, an intact tumor has clearer margins to delineate. So preoperative radiosurgery was proposed as a way to decrease this. And it was found to result in a lesser incidence of leptomeningeal disease than giving post-operative radiosurgery. Still, there are some active trials that are working on this. Regarding the outcomes, we look at the local control, the quality of life, and the overall survival for brain metastasis. The high-tech study that I mentioned was comparing the different doses, different lesion sizes. And it found superior local control with smaller tumors and inferior local control with larger tumors. Also, the histology was an important factor in the outcome of local control, especially non-melanoma histology, and BRAF-positive melanomas provide better local control. The ability to give a higher prescription dose, of course, and the control of the systemic disease at the time of radiosurgery. Regarding the overall survival, radiosurgery provides equivalent overall survival as compared to whole brain radiotherapy. As we know, the primary determinant of survival in brain metastasis is the primary, the systemic disease control. But the advantage of radiosurgery, of course, is the preservation of neurotoxicity. In the molecular era, also, as I said before, the primary is the main determinant of survival. So with the new molecular types of tumors that have been identified, they differ in the outcome, with EGFR and ELK positive small cell lung carcinoma providing better GPAs, and BRAF positive melanomas also better GPAs. Quality of life and neurocognition, of course, it is much better with radiosurgery, especially in the verbal memory. However, when radiosurgery is unsuitable, then whole brain radiotherapy with hippocampal sparing is sometimes used with concurrent membrane. Now, one of the main complications of brain metastasis treatment by radiosurgery, of course, is radiation necrosis. It presents the dilemma for us after treatment. First of all, its incidence is from 5 to 30%, and it is symptomatic in up to 54% of cases. It can start after a few months from radiosurgery and can occur even up to several years after radiosurgery. It is caused by vascular injury and release of inflammatory mediators into the tissues. The risk factors that have been found to increase the incidence of radionecrosis are the higher doses, the larger volume, repeat radiosurgery, and also recently immunotherapy has been suggested as a contributing factor to radionecrosis. So the dilemma is, after treating by radiosurgery, the tumor sometimes starts to show some reactive processes or signs and starts to increase in size, and we don't know if this is a recurrence or if this is radiation necrosis. Because by default, we in radiosurgery for brain metastasis, we have to have higher doses to control the tumor, so the radionecrosis risk is higher. So there are several investigations that can guide or help sometimes in differentiating between recurrence and radionecrosis. Specifically MRS with perfusion studies, the dynamic susceptibility contrast perfusion, which measures the blood flow or vascularity of the tumor, which is higher when there's tumor recurrence. The dynamic contrast enhanced MRI, which measures the permeability inside the tumor, which is also higher when there's tumor recurrence. Also, newer PET studies, FET-PET studies, lower intake in radionecrosis, and comparing of this maximum standardized uptake volume, the SUV max, can be used. The values can be used as a guide for indicating if there is actual activity inside the tumor or not. When there is a suspicion of the radiation necrosis, we start using several measures. We start with the first-line corticosteroids. Then, in refractory cases, bevacizumab has been used. It targets vascular endothelial growth factor-driven vascular leak. It was found to cause symptomatic improvement in 60 to 80% by 6 months, and radiological improvement in 88%. However, recurrence may occur up to 90% after stopping the drug. Also, there are side effects such as thromboembolism, hypertension, and intratumoral hemorrhage. More recently, laser or LIT, laser interstitial tissue therapy, has been used. In the multicenter Lateran study, they found that there was more than 85 radionecrosis resolution. 19% lesional progression occurred after LIT. The median time to steroid cessation was 13 days, and seizure prevalence dropped from 34 to 8% in 3 months, with a median overall survival of 2.5 years. In more serious cases, surgery may be the ultimate solution. There is severe neurological deficit or deterioration, neurological deterioration. Some adjunctive methods have been used, such as hyperbaric oxygen, which improves tissue oxygenation and angiogenesis, and methoxyphylline and vitamin E as antioxidants and antifibrotic combination. This is an example of one of our cases. It was a 49-year-old female patient with breast carcinoma. She had a right cerebellar metastasis. It was 1.2 cc, treated with 18 grays. At 3 months, the tumor shrank. Then, with the continuous follow-up at 4 years, the tumor started to apparently increase in size again. She did not have any symptoms, so we decided to continue follow-up. For the next 2 years, the lesion grew gradually, but then stopped growing at 6 years. The patient was still without any clinical symptoms, and she did not want to do any intervention for this tumor, so we continued follow-up. And you can see here at 9 years, this is her PET CT, there is regression of the lesion. Another complication of radiosurgery for brain metastasis is what we call pseudoprogression, which is usually a transient enlargement of the tumor after radiosurgery due to some inflammatory processes that can occur. It is it's a more benign and transient phenomenon, unlike radionecrosis. It occurs in 9 to 30% of cases, and it can occur from 6 weeks up to 1.5 years after treatment. So in these cases, we may go back to the investigations that we used before, either to differentiate if this is pseudoprogression or not. Another complication of radiosurgery is the leptomeningeal disease. The incidence here is 10 to 20% occurring after surgery. As we said, it is one of the risks after surgery for brain metastasis. Radiosurgery alone carries a low baseline risk, but does not eliminate it, particularly in cancer breast. It may occur more commonly in cystic metastasis due to intraoperative CSF seeding. There is pattern-specific prognosis in which nodular leptomeningeal disease after surgery provides better survival than the classic diffuse sugar coating pattern. The diagnosis and management, of course, is multidisciplinary. The prevention, of course, is the technique that we suggested before. It is the preoperative radiosurgery and a trial at meticulous surgical technique to minimize CSF contamination. There are some also histological factors that can complicate treatment. We know melanoma has the highest local failure rate among brain metastases. Some use ICIs, immune checkpoint inhibitors, before going to radiosurgery in asymptomatic lesions. The dose is individualized according to the site and the size, and multidisciplinary approach for sequencing with the ICI. In small cell lung carcinoma, they have a higher propensity for brain metastasis. So they usually do radiosurgery with serial surveillance for limited intracranial disease. Non-small cell lung carcinoma and HER2-positive breast carcinoma, with the recent targeted therapy concurrently used with radiosurgery, it has been suggested that this therapy will increase the risk of adverse radiation effects. Renal cell carcinoma have a higher rate of adverse radiation effects than other histologies. So there should be a balance between efficacy of dose and adverse radiation effects, and even consider hypofractionation for these lesions. This is an example of a case of a male 73-year-old patient with temporal scalp malignant melanoma who developed a left parietal metastasis. We treated this 1.6 cc tumor with 20 grays. At 3 months, we can see there was some edema, and then it resolved. Then at 9 months, we can see the tumor started to swell a bit. We followed up for another 3 months, then the swelling went away. So this was probably pseudoprogression. the tumor started to regress. Then at 16 months, the tumor started to progress again, and the patient developed multisystemic disease, and after 3 months succumbed to his disease. There are some special circumstances in brain metastasis that need special treatment, such as large lesions or critically located lesions, cystic brain metastasis, whether or not to use systemic therapy concurrently with radiosurgery. As we said before, the use of radiosurgery before or after radiosurgery. So first of all, for large or critically located brain metastasis, a newer technique for management other than hypofractionation is staged radiosurgery. In this technique, half of the dose is given to the lesion. Then we wait for a few weeks for volume shrinkage to occur. And then we give a second half of the dose at that time. The rationale here is to be able to decrease the dose to the normal tissue by decreasing the volume of the tumor receiving radiation, and also to make use of the 4 hours of radiotherapy, the deoxygenation, the redistribution, and the repair. We call this adaptive radiosurgery, in which you adapt replanning at each session on the new tumor volume. A study here by a Japanese and a Dutch group in which they had tumors from 10 to about 30 cc's and a CIT volume, cumulative intracranial tumor volume of less than 50 cc's, and still less than 10 tumors, a KPS of 70 or more. For 3-stage, they used 9 to 11 grays per stage, and for 2-stage, they used about 12 to 14 grays with a biologically effective dose of 51 to 69 and an alpha-beta ratio of 10. The usual interval for 2-stage was 3 weeks, and full course was 42 days. For the Dutch variant, they used 3 by 10 grays as a standard and 2 by 15 grays for more radioresistant histologies. The comparison between the 2 and 3-stage protocols, there was no difference in the survival or the control or the radiation necrosis. Well, the recommendation is giving a 3-week interval between each stage. We use this technique at our center. We used it in this lady who was 62 years old. She had breast cancer and she had a left cerebellar metastasis. In the first stage, the tumor was 15.6 cc's. We gave 13 grays. And the second stage, the tumor had shrunk, as you can see, to 7.5 cc. And we gave 12 grays. And as we can see, at 12 months follow-up, the tumor had markedly shrunk. This is another example, one of our cases in a critically located lesion. This was a 50-year-old female patient with breast cancer. She had a brainstem metastasis. The first stage was 4.4 cc tumor. We gave 12 grays. And 3 weeks later, the second stage was 3.3 cc. We gave another 12 grays. At 12-month follow-up, the tumor swelled a bit. There was some swelling and edema around the tumor. The patient was treated with a course of steroids. Then 3 months later, the tumor markedly shrank. In a comparison done in a meta-analysis between hypofractionation and stage radiosurgery, there was no difference in the local control or overall survival. There was mildly, although non-significant, difference between the radiation necrosis, which was more with fractionation. For cystic brain metastasis, these are another challenging group of tumors because the cyst provides a very large or increases the volume of the tumor that needs to be treated. It is independent of the size of the solid tumor. Their incidence is about 10%, most commonly from lung cancer. And lesions more than 3 centimeters in diameter or 14 cc's are unsafe for single fraction. The cystic compartment is independent, has an independent growth potential from the solid part, as I said. So to manage these, there is one of two strategies. The first one is to do a aspiration, stereotactic aspiration. The problem here is reaccumulation may occur in up to 30% of cases, or put in an Ommaya reservoir to enable serial aspiration with the catheter tip placed centrally, resulting in a more than 50% reduction in volume. It was found that median 80% cyst volume reduction before radiosurgery was achieved with the Ommaya reservoir group. And another meta-analysis, local control was better with placing in the Ommaya than the aspiration followed by radiosurgery. Another strategy, of course, may be because the cyst is large, then we can go for hypofractionation. It can be viable for cysts up to 3.5 centimeters in diameter or volume 11 cc or less. The regimens here are 27 to 32 grays in 3 to 5 fractions with good local control. This is one of our cases also, a 55-year-old female patient who had lung carcinoma and a left frontal cystic metastasis. The cyst was 27 cc's in volume. We did a stereotactic aspiration the day before radiosurgery. Then on the day of radiosurgery, we found the cyst had markedly reduced. It was 4.3 cc, treated with 18 grays. We were lucky enough that the cyst did not enlarge. It continued to decrease in size, as you can see at 12 months follow-up, but unfortunately, the patient developed other intracranial metastases. For the use of concurrent systemic therapy with radiosurgery, this study, the NCI cohort, found that local control was better with concurrent use with systemic therapy with radiosurgery. According to the timing, the ASTRO and SNO all prefer local therapy as the standard of treatment for symptomatic brain metastasis. For asymptomatic metastasis, some authors may defer focal therapy for lesions with specific criteria, mainly lesions that have a good response to systemic therapy, such as the EGFR mutant non-small cell lung carcinoma, the LK also, the BRAF positive melanomas, and HER2 positive breast carcinomas. However, it was suggested that radionecrosis risk is increased with the combined systemic therapy and radiosurgery. It is an area of investigation. Some TKI combinations report higher rates. However, several series show rates similar to radiosurgery alone. So the use of systemic therapy with radiosurgery should be used cautiously. As we mentioned before, the use of pre- and post-operative radiosurgery in order to decrease the incidence of leptomeningeal disease. It was suggested that the preoperative radiosurgery be used with surgery occurring within 1 to 4 weeks from radiosurgery. This is a proposed management algorithm for the management of solitary brain metastasis. On the left side, your left side, you can see 4 accessible lesions that are amenable to surgery if the patient has a neurological deficit. Then patient can undergo surgery. If not, then can go for radio surgery or fractionated radiosurgery. After surgery, post-operative radiosurgery can be given. For smaller lesions, depending on the molecular type, for melanomas and breast HER2 positive and non-small cell carcinoma that are EGFR positive and ALK positive. If they are asymptomatic, they can start with systemic therapy, with or without radiosurgery. If they are symptomatic, then go for radiosurgery immediately with targeted therapy. Smaller lesions, other histologies, if the patient is asymptomatic, can go for radiosurgery or fractionated radiosurgery. And for symptomatic lesions, systemic therapy may or may not be added. On the right here, another column for what we call adaptive radiosurgery. This is the staged radiosurgery technique for large or high-risk lesions, which are unfavorable for surgery. Then we can do the first session with half the dose, then wait for a 3 to 6 weeks interval, reassess the tumor volume, and then give the other half of the dose after the tumor had shrunk. This, as I said before, it provides for better or decrease the risk of radionecrosis adverse radiation effects. However, if the tumor does not shrink between the sessions, then we can cross over to the previous technique, which is preoperative radiosurgery. So for our take-home messages, radiosurgery is the first line for solitary brain metastasis. It is focal high-dose radiosurgery tumor control that is comparable to whole brain radiotherapy, with the advantage of preservation of neurocognition and quality of life. So radiosurgery alone is preferred over radiosurgery and whole brain radiotherapy. Patient selection, KPS 70 or more, prognosis of 6 months or more, lesion size 4 centimeters or less. These are the core criteria, but also there's the disease-specific GPAs and emerging radiomics and NLR markers to refine prognosis further. The dose depends on the size and the fractionation strategy. For single dosing, the RTOG, it works better for smaller lesions, less than 2 centimeters. Hypofractionation for larger lesions with comparable control and lowering the radionecrosis risk for larger lesions. Post-operative cavity radiosurgery is now standard. It's preferred over whole brain radiotherapy. Preoperative radiosurgery is an emerging strategy that markedly reduces leptomeningeal risk. Radionecrosis and pseudoprogression need multimodal imaging to differentiate between them, the MR techniques and the PET. Large or critically located lesions can be safely treated. Stage radiosurgery and hyperfractionated regimens achieve equivalent local control and survival for 2 single session radiosurgery. With stage approaches now can be used to lower radionecrosis risk. Concurrent systemic therapy boosts local control, improves local control, but may or is suggested to increase the radionecrosis risk. Key open questions that remain, of course, the timing of radiosurgery after surgery, pre or post, the ideal hyperfractionation scheme, and the management of radioresistant histologies such as melanoma and renal cell carcinoma. Thank you.
Thank you, Dr. Shahabi. It's pretty comprehensive look over the stereotactic radiosurgery for single brain metastasis, solitary brain metastasis. Dr. Salzuk, do you have some questions for our speaker?
So thank you so much, Amr. It was a very nice presentation about this very important topic. In some centers in the world, in radiosurgery centers, I mean, more than half of the patients are with metastasis. So this is a very important issue. As a neurosurgeon, when I was a resident, metastasis was a diagnosis. We don't want to work on it because most of the patients were dying in a few months. But today, with the improved treatment of cancer, we do see a lot of patients, they live a lot. And in some patients, we can see the cure of the disease. So metastasis become a very important issue for a neurosurgeon. And I think today, most of the metastases, if they need a local treatment, are treated with radiosurgery, not with surgery, not with radiotherapy, but radiosurgery. So all neurosurgeons should be informed about radiosurgery for metastasis. That's very important. And I want to say that if a patient's metastasis, if there's a small metastasis, we mostly use radiosurgery, of course. But for the larger metastasis, larger than 2 centimeters in diameter, we have to think about to do a surgery or radiosurgery. My personal view is if the patient's neurological situation doesn't force us to do an immediate surgery, we should choose radiosurgery because we have a lot of different options for radiosurgery. Stage radiosurgery, hypofractionation, low dose, high dose, etc. So, and of course, if the patient needs a surgery, we have to think about neoadjuvant radiosurgery. So for many metastasis patients, we can help them with a kind of radiosurgery. So I think for the young neurosurgeons today, for our residents and the young fellow friends, to learn about metastasis treatment with radiosurgery is maybe the most important thing in their daily life. Thank you so much for this general overview of this subject. May I ask you for your personal policy for the large metastasis? You said that you are using stage treatment and also you can use hypofractionation. How do you choose between stage treatment and hypofractionation treatment for a large metastasis? What is your policy?
Yeah. First of all, I want to also press on what you said before regarding brain metastasis. Now we are seeing patients that are living many years after their diagnosis. We have patients that are following up with us for now up to 10 years after their initial diagnosis because now the systemic therapy has become very advanced. And with the use of radiosurgery, the patient can have a good quality of life for many years without the complications of whole brain radiotherapy. So that's a very important issue to stress on. Regarding large tumors, we don't usually use the hypofractionation technique. As you suggested, for a large metastasis more than 2 centimeters, if the patient does not have grave symptoms, then we can go with the staged radiosurgery technique. We give half the dose for the tumor, wait for 3 to 4 weeks, and then wait for the tumor to shrink, and then give the rest of the tumor, the other half of the dose. One thing also that we have found that after radiosurgery, the patient may come at many times with a tumor and a lot of edema around the tumor at the time of radiosurgery. Then after radiosurgery, find the tumor has shrunk and the edema has disappeared. What about the cases in which the tumor does not shrink? The patient has a large lesion. We tried the stage dose technique, and the tumor did not shrink between fractions. If the patient remains neurologically sound, then we can continue follow up and wait and see if the tumor shrinks. If the patient does not, then we can go for surgery after that. So he has shifted to the preoperative radiosurgery technique. so as he has the advantage, the added advantage of decreased risk of leptomeningeal spread if he's going to go for surgery.
That's another important issue, because when you need to apply post-operative surgical bed irradiation, of course we have to do in some patients it, because they are sending to us from other centers. We do see the risk of the leptomeningeal disease dissemination is high. So we don't like to have a patient who had a surgery before some time and to irradiate them. So, for example, if you have this kind of patients, how many days or weeks you wait for irradiation in for the surgical bed irradiation, I mean?
Usually not less than 3 to 4 weeks, so that the surgical bed is free from blood residue and all of this tissues.
In our center, we almost always wait for 3 weeks. That's always same to you. After 3 weeks, we do it. And the other thing I want to say lastly, the LIT is a promising treatment for radiation necrosis today. In our hospital, we don't have LIT, but in other hospital in Turkey, other hospitals in Turkey, they have LIT in their hospital. So LIT seems to be a good option for these patients with radiation necrosis after radiosurgery. And I think if we are trying to get a LIT to our hospital also, but what we do use steroids, bevacizumab, etc. And I think LIT is becoming more and more used thing for the radiation necrosis in these patients, because if the patient lives long, the risk of radiation necrosis become higher and higher after some years. We may see it. So it's another important option, important issue, as you said. Thank you so much. Please, Manjul.
Shabi, one of the important points you told today is about the cystic metastasis and the use of aspiration, volume reduction, and then giving radiosurgery. So if you're not using an Omaya, you are just doing an aspiration, doesn't it increases the chances of LMD in these patients? Because the cyst may contain some viable tumor tissue.
Of course, this is a risk that can happen. Of course, in some cases, the CSF, the cystic metastases have a higher propensity for leptomeningeal spread. But with careful stereotactic technique, maybe, and putting the target in the middle of the cyst, that may, as much as possible, decrease the incidence of this spread. Also, we try and arrange for the radiosurgery to be done the second day after stereotactic aspiration, so as to try and minimize that. Of course, Omaya is a very good option that keeps gives you a peace of mind. You can just put in Omaya and then you can forget about the cyst after that. I think in later on the cases we did after that, we used Omaya more frequently than stereotactic aspiration.
Since you have been practicing with this metastasis for closely now for 5 years, and there have been some significant changes, like from post-operative SRS to the concept of the preoperative neoadjuvant SRS. And now there are discussions about the BED and the AI and the liquid biopsies and the radiogenomics. So what, in your opinion, what is going to be the single biggest change in the next 5 to 10 years in the management of these metastases? Are we moving towards the AI, or we are going towards the radiogenomics? Because all of these separate primaries, they have a very different behavior, different IHC, different propensity to come to the brain, different chances of metastasis. So what, in your opinion, is going to be the next big change here?
I think moving more towards radiosensitizers. because as you said, different tumors have different histologies, different molecular makeup. With new systemic therapies, maybe some radiosensitizers can be added to these systemic therapies in order to improve the results of radiosurgery after giving the radiosurgery. So I think this is the next step in the management of metastatic tumors of the brain.
One more very common question which usually happens when somebody is coming with a solitary brain metastasis, we do all the metastatic workup and we fail to find a primary.
Yes.
Now the question happens whether we should treat it with a primary radiosurgery or we should lean towards the surgery so we can have a histopathological evidence in our hands. So what's the policy and in how many times you are actually surprised by the outcome?
Actually, per our policy, if we don't find a primary for this tumor, then we do not give radiosurgery because unless we have a histological diagnosis. So either stereotactic or open surgery. If there's no other primary, and sometimes we can lean towards use MRS with perfusion study in order to bypass surgery. But we have to have a pathological diagnosis before proceeding with the treatment. Sometimes, of course, many times we were surprised by results. Many times we've treated tumors we did not think were metastases at the beginning, and then we found out that the tumor had disappeared, and then patient later on was diagnosed with a type of cancer. It occasionally happened a few times. So it happened. It's one of the issues that have to be dealt with.
Again, the literature reports that there is a discrepancy in the IHC markers in the primary and the secondary of the same tumor. So probably they suggest that biopsy should be a gold standard in all these cases because the IHC of the secondary in the brain might be different from the primary tumor, and then the targeted therapies and the immunotherapies may differ in their approach.
Exactly. That's why we prefer to have a histopathological diagnosis.
So if there is any question from the audiences, we will be happy to have it. Please feel free to ask your questions to Amr.
You can unmute yourself and then after introducing yourself, you can ask the question, please.
In our textbooks, it is written that in almost 10% of the intracranial lesions in a patient with cancer may not be a metastasis. They can be a different thing. But I think today, with the improved MR techniques, this rate is lower than 10%, not so much, because we have a lot of different techniques for MR. But of course, as you said, that in some patients, we do still need to have a histopathological or sometimes a molecular study for the lesion. You are right.
If there is no other question, I would suggest probably most of the audience today is the neurosurgeon. And this time, the organ-specific molecular therapies, targeted therapies, they have improved so much that you need to be aware of these techniques because there would be discussions once you are sitting in the tumor boards, whether to take patient for surgery, only for SRS, only for immunotherapy, wait and watch. And not only the technique and the dosing and all these nitty-gritty of the SRS, you need to know the exact sequence in which you need to administer these techniques. As Dr. Shahabi rightly told, I like the word of the crossover SRS. Like we are going with the adaptive SRS for a large tumor. And if at any point of time we feel that this patient now needs a surgery and then they cross over to the preoperative SRS group. So this is a beautiful thing. Professor Packer, I remember your article on the large metastasis, especially in the posterior fossa, which we treated with the adaptive SRS, and they had such a beautiful volumetric reduction. And I think those majority of those patients, if these techniques are not there, they might be subjected to conventional surgical approaches. Operating in these patients who are in the later stages of their life, in the frail situation, surgery is not a very good option. It's only should be taken as a rescue one. So if there is no other question, I sincerely thank our esteemed speaker today, Dr. Shahabi. It was a wonderful talk and wonderful discussion, and my co-chairperson, Professor Saldu Pecker, and all the attendees today. I'm so happy.
Thank you
Thank you all so much. Thank you. It was very nice to see you again.
Nice to see you both again.
Bye-bye.
Thank you,
everyone.
Okay.
Bye-bye.
Bye-bye.
Let's meet on the
Thank
next
you so
time.
much. Bye-bye.
See
Good
you.
day.
Bye-bye.